Welcome, everyone. Hello, good evening. We're all familiar with each other by now. My name is Victor Domenech, and this is the eighth session of Digi4MSK. We've managed to bring in Raquel García Tarrazo. It took her some time, but she's finally here with us. So I don't think anyone is listening to the interpretation into English.
For those of you who are connected and want to activate the English translation, just remember to do that. You have at the bottom the option to activate it.
I am now going to share my screen. And I lost habit because until now, all webinars have been in English except for Kika's and Mark's. Now you know him well. Well, as I said before, our guest today is Raquel. Thank you very much for accepting our invitations. She is a collaborator of this project because she is contributing with materials that will be used during during the courses. And I'm displaying now on screen a link to pre-register to them. They will become available starting September. So we will keep you updated, but if you want to pre-register for this, because it's about self-management and improvement in self-management, well, you can just go ahead and register now. And just for you to know, when the webinar is over, we will share a link on the chat with a satisfaction survey, and we encourage you to populate it because it's really useful for us. Okay, I'm now going to stop sharing my screen. And without further ado, I asked Raquel to deliver a brief resume to introduce her, and she was very succinct. She was very, very brief. We could say much more. She wanted to emphasize that she is first and foremost a clinical therapist, physiotherapist. She teaches in different degrees and different courses to train physiotherapists on digital management. Muscular physiology and some other topics. Well, I also work on exercise prescription and some community work, which is some of the topics that I frequently go back to. And she asked me to mention too that she's a member of the physiotherapy group of the Spanish Pain Association, and she is more than welcome to join us. And now we're going to be talking about digital interventions for roughly an hour, focusing on self-management and musculoskeletal disorders. So the way this is going to work is the following. I will ask questions and they will probably turn into a conversation. At some point in time, Raquel will be sharing her screen to support with images or explanations. And in the last part of the webinar, we will open the for Q&A. We will open the floor. You can post your questions as we go, and in the end of the webinar, we will respond to the audience's questions. So where could we start, Raquel? Well, perhaps by something general, which is the causes or the social or time context that make these digital interventions relevant, something to be borne in mind, and one of our basic tools in our toolkit. Some of the things that I realized when I was preparing for this webinar are that indeed all of us do digital interventions, even if it's in an asynchronous manner. Maybe there's the bias that a digital intervention is what is structured and synchronous with patients, like we're doing right now. But rather, it's to be thought of as anything done digitally with patients. Actually, when we talk about the term digital health, even the searches that you have documented of patients in the internet are part of that digital healthcare in a way. But the thing is that everything digital is ubiquitous right now. All professionals do it. For instance, clinical history is also digital. And then we have interventions with patients, and there is quite a wide array of naming the teledigital physiotherapy. And this is something geared towards delivering treatment, doing specific visits or examinations. So in this way, you can do a face-to-face, synchronous, real-time visit or an asynchronous one through messaging, through apps, through email, or even through patient applications that are not really overseen by the professional, but rather they just feed contents as they want. There's pain management applications, like, for instance, Curable, which is available in the UK, and it includes cognitive behavioral um, approaches, active treatment, and sometimes there's also a gaming approach so that patients can meet their milestones. And of course, this is ever present in many spheres, and healthcare was not going to be any less. And in the pandemic, there was a boost of this type of approaches. Because there was a need to be met, and it seemed like these televisits were going to prevail, but they haven't as much as we thought. There's been, in a way, a valley. They have become stagnant in a way. And this goes back to the reasons why this came about. In the beginning, in the pandemic, it was obvious why there was a boost in this digital therapies because people didn't have the capacity to go to places. But what are the rest of reasons that make this still relevant? What motivates us to continue to use digital interventions? Because actually, in our preparation for the project, we detected a great need, and this was very much aligned with needs established by international bodies like accessibility, inclusiveness for low mobility individuals, reducing commuting, reaching out to people who are perhaps far from you, and through televisits, they can have access to you as the reference professional. So, what do you think are the main reasons that cause digital interventions to be something still relevant in spite of the fact that there's been a decline of in their use after the pandemic? Maybe I could use a slide. Yes, you can go ahead and share your screen. Let me try and find the slide that I wanted to display when talking about the advantages. And here it is. Am I successfully sharing my screen? You are indeed. There it is. Well, advantages of digital physiotherapy. This goes back to what you just said. During the pandemic, it was clear why it was needed. We couldn't leave our homes. We were in lockdown. There were restrictions for transport, legal restrictions, and this also actually helped us deal with the potential risk, because right now we're talking about musculoskeletal patients, but there's people who have musculoskeletal disorders that are also immunodepressed. So it's a way to reduce the risk of infections. They can do the treatment from home, or even for patients that have chronic fatigue or um, um, fatigue that's debilitating and that hinders their ability to get to the clinic. Well, that energy, that limited energy that they have to move, is something that could cause these patients to be able to benefit from this type of therapy so that they can adhere and they can do physical activity in a different way. And there are some other advantages apart from what you mentioned: equal access for rural areas, for instance, where there's not a great number of specialists, or in order to reduce commute time. Here in Asturias, where I'm based, it does happen because um, peri-urban areas don't really have all the specialists available, and they need to come to main cities to have access to them. So that would meet a need. Also, in addition, you reduce the carbon footprint, and also we reduce the amount of materials that are used during the session, and you eliminate transport barriers, and it can be more flexible. It's saving, it entails savings because the time of the session is what it lasts. You know, you don't need time allocated to transportation to get into the session, etc. And in terms of cost effectiveness, there are some doubts, but it depends on the format. If all sessions are one-on-one and live, or if there's some sessions that patients can self-administer after having had the visit and they don't need to attend the center. Um, this would be quite positive for the center too, because that would shorten waiting times to queuing. You can keep track of what they did. You can see whether the patient executed the session, they completed the exercises. There's some tracking capacity. But for mutualities, for labor-saving charities, I know that some of them are interested in this type of interventions. And they say, okay, patients need to do this many sessions. You're not going to be completing all of them at the center. And it's impossible to track this at 100%. But that way you can make sure that the exercise app is open during the time that you deem relevant for the session, and that um, at least you can keep track of that. So it could be helpful from that perspective. When you need to do some sort of intensive type of treatments from home, it's more it's easier to do it from home, and sometimes patients with low back pain say I cannot bend over to pick up something. So during the consultation, they can replicate the situation, but they're not doing exactly that, I don't know what, that they cannot do when they're at home. In their own setting, you can truly replicate what it is that they need help to do, and you're helping them do the gradual in vivo exposure. Uh, for them to be able to perform the task that the patient fears or that generates pain. And that way it helps you understand the task better because you can see it on site. And some studies say that digital tools can improve patients' adherence. Actually, the patients in doing supervised at home exercises have better adherence to their prescribed exercise plans, and because oftentimes they're not accompanied and they're given a certain responsibility, this can improve self-efficacy, and all digital tools help data monitoring indeed for patient follow-up because indeed it's much easier to do. It's at the palm of their hands. Some apps can tell you whether they had pain, the perceived effort ratio, PRMOs, etc. And clinically, that could be used so that you can show the progress made to the patient objectively. So if this is populated, it can be a secondary clinical resource.
Yes, I fully defend always having data. Perhaps they won't all be useful for pain improvement. That's what the patient is asking for. But if there is an improvement in any strength test or mobility, well, in that case, we would be providing the patient with that improvement and telling the patient, okay, we're on the right pathway, and with all these exercises that you hadn't been doing before, now you are healthier and therefore you are improving your health, whatever you want to tell the patient, something that will be relevant for us as professionals. But this will be very useful for our patients in this road towards the final goal. And this, as I say, will be something extremely useful. Now that we have this slide, I would like to talk about adherence. Recently, we attended the Congress from the Pain European Federation, and we were talking about adherence versus compliance, the compulsory compliance of exercise prescription. So the question I wanted to ask you is what you do with this digital media follow-up. Of course, you can be with the patient almost every day. You cannot ask the patient to be on the consultation every day or almost every day a week. But of course, if we use these digital tools to show them the progress, this will be very useful. But how would you explain to the patient this digital follow-up so that the patient won't be feeling that, you know, he's under watch or that he needs to compulsorily follow this prescription? What do you think about this adherence? Okay, I will now share my screen and will reply to you. What do I do with my patients? Well, if they are not active patients, in that case, I make a negotiation with my patients and I always start with a minimum threshold. My question is, if you are being honest, how many days a week can you be committed to this exercise prescription or rehabilitation? So I let them choose these temporal windows. Sometimes they want to say, okay, no, I will do it half an hour every day. And then I ask them, are you sure you can make it half an hour every day a week? So what I want from them is to tell me the minimum threshold, and that's what I take from them, because oftentimes patients who are experiencing pain, they are not in the best mood, or they are overwhelmed with the situation, or they are facing some family issues. So for me, a biopsychosocial interview will be extremely useful. For example, if I have a patient, I will talk about a woman. Let's say there is a patient whose parents are very old, are not doing well. She's enduring a lot of stress and a heavy load. In that case, I will try to make it easy for my patient because, of course, the context is not the best one. And I need the rehabilitation not to be an extra load for that patient. That's why I make this negotiation with my patients. I very much try to understand what the context is, how their daily life is, when we could place this exercise. If we are talking about the elderly, in the morning they are very active, but then in the afternoon, in the evening, they are on the couch. So I try to make them stop this sedentarism. And for example, if they are more active in the morning, they could do whatever is more difficult for them because they will be more active. This is what I try to do. So this is what planning is about. We plan for the week, the different time frames, and when the patient will be able to follow these exercises. For example, I have a patient who makes the exercise every day in the afternoon, and I say to her, okay, you cannot have a snack until you make this exercise. And then she sees it as a reward, you know, like, okay, once I am done with the exercise, I will be able to have a snack. So I try to know what the patients will be doing on their daily lives. For example, I'm brushing their teeth or something with a microwave. Okay, at the same time that you are putting the coffee on the microwave, you can do this exercise, these kind of things. It has also been seen that people with a sedentary life, they will experience good feelings with moderate exercises. Of course, if they are not making any exercise, they want to see the reward from doing this. And therefore, when we are talking about these patients, it is better to have a moderate exercise. In those type of cases, we do not need to say this as something on the long term, but rather working little by little on a day-to-day basis. And what we do is to try to be consistent. I will prefer a low threshold, but doing this on a daily life basis, because what we want is to have a good behavior. At first, the patient will look at me like, oh no, I'm not going to do this at all. And then we won't go anywhere. But then when they try exercises, they feel more comfortable, and perhaps they ask me, okay, I want a specific exercise. If it's a patient with a low back pain, then I will prescribe him or her some specific exercises for that area of the body, or for example with that movement pattern, with a specific exercise because of the metabolism reason, whatever that might be. So there can be different purposes for this exercise prescription. There can be many interventions on many different levels, and we will choose what the priority levels are for the patient. In that case, we will provide the patient with different options, and we will ask, okay, do you want to do an exercise for big muscular groups, for example, for the legs instead of the arms, the back chain, or we could do a hip thrust? Well, we can make some tests at the consultation and ask the patient how they feel comfortable, how much exercise they could do, not to feel too tired, and then with this we repeat this all over again. Once this is consolidated, once we are doing well with all of this, then we will explain the patient, okay, now we need to make progress, because if we do not make an overload, then we won't be able to improve. We need to make it a little bit more difficult, etc. So you try to emphasize why they have to do this exercise as a key aspect of motivation and adherence. I want them to understand why they are doing this. Yes, I talk to my patients about everything that needs to be told. If I need to talk about something very specialized, I will do this. So, okay, you will adopt this and adapt this to the different level of the patient. Sometimes patients are very much interested, or they have a more scientific profile and they want to go in depth to this. In this case, we're talking about behavioral psychology, and there will be some patients who have, for example, musculoskeletal disorders. They can have comorbidity, and if, for example, if we have a patient who has pain and it is very difficult for them to activate, perhaps we will need a model based on beliefs, and in that case we will need to talk about that fear for the patient to be adherent, because otherwise the effect will be negative. But on the other side, we can have a patient who is experiencing pain. This patient doesn't have any pathology, it is just a primary disorder, and we just want an activation and not an exercise prescription, but rather just some physical activation. So I guess you try to adapt to the patient, and I guess you also make this negotiation on the first consultation with the patient. Do you do this on site? Can you do this from the very beginning on a digital format? What do you do, and what do you think is the best result? Well, I have some patients who are 100% digital, and they contact me and they come from different geographical locations, and with them it is 100% digital. But I also have other patients who come to my consultation and it's a 100% on-site consultation. They come to me because they couldn't find a solution in other places, and I always try to explain that the exercise won't have immediate results. That's when I use the different tools about monitoring, follow-up, etc., and I make that exercise prescription. But other times I just draw this in the blackboard. They take a picture. Well, with the phone, this can also entail a digital side. Sometimes it is a very simple thing. You just write this, or you can answer a question, or you can call them. That's the kind of follow-up. And then you won't see them up until 3 weeks later. I always try to adapt to my patients. And when we are talking about digital patients, I do not try out all the exercises. The literacy level of the digital patients is very high, and they are very much willing to do these exercises. They have a good knowledge about their bodies, and it is easier usually with these kind of patients. Of course, if there are some doubts, I will try all the exercises also with these digital exercises. I want them to see whether they are making a good execution. Some people are fearful of doing this in the wrong way. And we also intervene in the process of refuting bad beliefs. Some years ago, out of my lack of experience, I gave them a lot of information in the first and second consultation. So I guess it was very dense, right? Yes, and it was overwhelming for my patients. So now I base my exercises on the needs. It's like, okay, if I say the hook, for the hanger, for example, in that case, I try to see how I can make a good use of the doubts they might have. And then I try to make them have these shifts of behavior in order to go out and live out of that problem. But I do not do this just at one go. Yes, and there are different education models that talk about the minimum threshold with patients with this low risk. Then there is an education session. And in case we have some complex patients, we can dosify this based on the opportunities, and we can make, well, a good use, as you said, to find that hook. Yes, you find the hook and then you find the hanger. That's right. And you were also talking about the health literacy, and this is very interesting. Within our project, we think that literacy is key for self-management. This is also approved by the WHO. In order to implement self-management, this will entail a behavioral shift, and for that, an acceptable literacy is required. And you also mentioned this for digital interventions. Of course, age could be a barrier if we talk about the technological aspects, but at the same time, a low literacy and low skills to find information about health, that will be a barrier, right? What do you do in those cases? Is this a mixed model, or what you do? Well, if they have a low literacy, this can happen with on-site and digital patients. In those cases, low literacy will entail a low knowledge of health, but this can also be seen when it comes to the use of digital tools, etc. So in order to make the difference between the on-site and digital consultations, we need to adapt this to the different patients. For example, in my case, I have some PDFs with the step-by-step procedure on how to connect. Sometimes I call them and I explain them step by step what they have to do, where they have to click, etc. And other times they need the help, the support from a family member in order to be able to follow this consultation. They need this tutoring at all times, or sometimes they need this in the very beginning, and then they can do this on their own. This happens especially with the elderly.
It really varies between countries. It really depends on the digital development in place in the country. There's also gender differences and also between rural and urban areas too, and also the level of school education that they may have. Okay, we have talked about a barrier to digital interventions, but we can talk about additional barriers. You've talked about literacy, but there's other things that you need to mention on this subject matter, right? You have a support in the slide, right? Yes, I do. In addition to digital literacy, we also have technological access. Not all the individuals have a good internet connection, even though almost everyone in the Western world do do have smartphone. Some elderly people don't have smartphone or a tablet or a computer, so that's a big barrier that makes it impossible. And also, talking about the professionals, the disruption of the workflow is relevant. You don't really know where to fit in those telecom consultations or the digital management of plans. As part of your working day, you need to create space to do that too. And I began during the pandemic, and I was under lockdown, and I didn't really mind. I could do this anytime. But then physical consultations came up again. And in the beginning, I arranged my teleconsultations when I was back home. And that it was not sustainable, was it? No, it was very invasive with my personal space. So I always do this from my office, from my physical office. And sometimes, if one of my children are ill and I need to cancel my physical and my face-to-face consultations, they need to be canceled, but not digital ones. They can watch cartoons for a bit, and I can have some sort of work-life balance. And then we have the resistance to change or the reluctancy to change. And sometimes for some people, strictly digital consultation is too new. And for many people don't really understand how you can do or receive physiotherapy in this way through passive therapies. And people believe that you always need to lay your hands on the patient and that you need to use devices. And this is deeply rooted as part of our profession. And then we also need to understand now what the status or the situation of the patient is. Some people that have sensory conditions, blindness, deafness, etc., some unstable disorders such as arrhythmia or their heart rate levels spike, and have balance disruptions, and they're not accompanied by anyone. And those things hinder this type of therapies. They need face-to-face therapy because they're better supervised that way. So sometimes the condition of the patient is a limiting factor. Talking about passive therapies too, I often see digital interventions over video call that have some limitations to do some things, but sometimes I see them as opportunities. And I think everyone at some point should try and do some sort of call of this kind so that they can actually see how they can manage these patients without laying hands on them. For me, this was very disruptive. When I was treating some patients that were complex and I treated them online and I was seeing results, I thought, wow, because I was always biased. I thought that at some point you had to do something manual, maybe applied tens or something like that. And in the physical consultation, I often do this, but in a way, for me, it was like getting rid of a concept that this helped me to see that this was not necessary. As you know, I work with academia and I do research, but I do see patients a few hours a week. I don't know if it happens to you, but the traditional model by which you're supposed to do physiotherapy by touching the patient, I more often do consultations by which patients want to have just functional assessment, or they have some sort of musculoskeletal issue that has to do with pain. They just want wider guidance. Um, I think that this objective that some patients have fits very well with digital interventions too. I think it would be easy to cater to this. They want an opinion, they want an assessment rather than a hands-on treatment. Or of course, you can do physical examination sometimes over digital means, and after that assessment, you could provide your professional opinion. And maybe they're at a key moment of their health journey. They're going to have surgery, or they need to be more active. They need to do more exercise. That would be quite appropriate for some situations of that kind. Yes, I do think so. I think that we need to stratify patients, and some of them we can manage them in this way. In public systems, of course, it would entail savings and it would free up working hours, professional hours, to deal with other cases that require um, more supervision. And this clearly collides with the approach of private healthcare businesses. They would have to work more to fill up their agendas, maybe, or the diaries. But this is the way we work, and I know that it's more difficult to have a very busy diary if you work in this way, but we believe in this and we support this idea, and this is the way we work. And of course, I do think that this should be escalated. You have something that has a good prognosis, you are reassured with the approach, and I can explain things to you over this means, and I tend my hand out to you so that we can do things, different things going forward. But in principle, I consider that that patient doesn't need to physically come and see me. But some other people do require that type of approach due to several reasons, and you can provide that too. But I think this is not person-centric care. I mean, being patient-centric is focusing on their need. Not everyone needs low supervision. Some people don't have the capacity for that, and some people will never have that capacity. And that's something that we need to embrace too. That type of patient profiles, they really need a high frequency of consultations. And I mean, we cannot get upset with them. You need to set them free in a way and let them do their own thing, but not everyone has the capacity to do that. It would be utopic to think that. So you need to adapt to patients, and that's the way it should go. And I mean, for some things, digital approaches have no different to the face-to-face approaches, except for the examination. If you want to, we can talk about that. Earlier on, you said that this is underestimated in research or in terms of therapy effectiveness, or sometimes we compare the public and the private systems, and I think this is a very relevant variable. And there, it really has an impact whether the patient is paying for each session or not compared to the public setting. And it's a context that can really mark the patient's behavior. So from the standpoint of healthcare systems, it's quite clear that in Western countries, we will have to do something because of the population pyramid, because people are aging and there won't be enough healthcare professionals to cater to the demand with the same care quality that we have. In the United Kingdom, for instance, they are encouraging all healthcare professionals, even the pharmacists are encouraging low risk patients to not go to the doctor's office. They can even be taken care of by the pharmacist if that is enough. And you also mentioned something that is very important, which is whether the patient requires low or high supervision or oversight. This is something that we take into account very much in our project. We are using instruments to measure musculoskeletal condition. And for instance, if there is a very low health literacy and they need high oversight, we take that into account. Or if the prognosis is good, they're very literate, and they're very much adhere to the treatments. We need that to take that into account. So public, private, the level of oversight necessary for the different patients, that's something that you also take into account in the context of digital interventions, of course. And we need to talk about what we consider to be efficacy too, because we always assess efficacy based on whether the patient stops needing us at some point. But maybe perhaps that a patient can lead a decent life if you are there with a certain frequency, and perhaps you're very much decided on setting the patient free, on releasing the patient. And some patients are really not solvent. We all have cases of patients that are really not solvent. They don't really register the information. They have a lot of cognitive rigidity. They're very anxious, and they have psychological factors that very much mark their vital history, and they need support. And maybe they don't really have a super severe health issue or bad prognosis objectively, but their bad health perception is very intense. So for those patients, sometimes you can do re-education, and sometimes they won't be able to be re-educated. So digital interventions are not for everyone. That's right. I actually have a patient for which I do digital interventions, and she's very smart, and she's very intelligent, but she worries a lot, and she has low pain thresholds, 2, 3, but she really needs to hear from someone that she can go ahead and train. She can do exercise. And I always tell her, if you don't have a pain that exceeds this level, if if you don't suffer, you can exercise. And I get tired in a way of repeating the same mantra because it's always the same narrative. But she does 100% digital intervention because she lives in a different region. But she needs that reinforcement very frequently, regardless of how you do this on the platform. Yes, for that, the digital approach is much better, and you can do this reinforcement that some patients need over a platform or over a messaging. Yes, we do messaging. She writes me once a week, and she says, I felt pain when doing this, and I say, don't worry, you can do this and that, and that's a brief intervention. It lasts a minute and a half, actually. And sometimes some physiotherapists deliver specific information over this digital approach. Well, wonderful. We're being asked some questions. You made reference to the physical examination. Could we speak about this? How do you do the physical examination digitally? And then we can go back to the chat's questions. I just wanted to share a few slides. So I wanted to specify just 3 things that we can measure. Here we have joint range that can be measured in several ways. You can compare pictures pre-post surgery or day 1 pictures if there is some joint movement limitations, and you can do the flexion and rotation pictures and compare those pictures over time, and that can be done in a synchronous way by doing script captures, or asynchronous. Always, if you're going to do screen capture, ask for permission, please. And you can use apps. You can use apps that use one of your pictures in your gallery, like actually the pictures that I have here, marking the angles that we have here on the knees or on the hip, or here you have the dorsal flexion. You can measure from how many centimeters away from the wall they can keep their second toe. And these are things that we can do that we normally do in our face-to-face consultation. And digital goniometry has very good correlation with the analogical test. So this hasn't been included here, but for face-to-face consultations, I use the digital goniometer, and it's very simple to implement. You use the phone to measure a segment for a knee flexion. You use it on the femoral part, and then you use it on the tibia, and that way you can actually get the patient to download the app while you deliver explanations over a call, right? And that way they're entertained gathering data. And some people are very much keen on gathering this data. Some people really enjoy this. And then we have orthopedic test. And there's several that can be self-administered. If you are a great supporter of orthopedic test, very well executed, maybe this won't work for you. But I find it useful to reach or to close my diagnostic hypothesis. If I want to determine the articular pain, they can do a Favre, and they can see what the maximum movement is with a load, and that way this way you can rule out some of your options. And this is like in real life. If you group everything around clusters, then specificity becomes greater.
Yes, and not all those exercises can always be done. For example, if it is difficult, you will need some replacements. Or, for example, when we talk about the abrupt heel test, well, some kind of guidance that will be very useful. Of course, you cannot have a digital cluster for every joint range, but you can have some approximate examination. You can obtain this information if you talk to the patients, or what's the pain territory, the pain behavior, whether it happens in the morning, in the evening, paresthesias. Yes, of course, and the medical history will be more important than anything else. Yes, and actually you will choose your orthopedical tests based on the medical history and the narration from the patient. So first you listen carefully, you ask for the data that is missing, and then you will choose what you will be doing, and this will be a differential diagnosis. So of course it doesn't make any sense to carry out the tests to everyone. You can make some adjustments based on the patients. In this case, this would be an adaptation. In this case, it is the meniscus. What we do is to rate them, to load, to make the shifts, to see the knee expression, and those are the kind of adjustments that we do. And also the resistance can be done with the hand or with an elastic band if we want to make a special test with the shoulder and we want to know whether it is painful when we make these rotations, etc. So yes, there are lots of things that you can do. And oftentimes there are many good results in the digital consultancy. It is not that I have this bias, but the literature also supports this. And in order to measure the strength in muscular tests, we can do different ways. Of course, we can have some very low cost materials, and these are reliable as well. In this case, we can compare the amount of times that a patient is making a gesture with a muscular group, or in this case, we can see the heel elevation, or in this case, with the neck, how much time this patient can endure up until the failure. We are going to measure the strength of your neck because this could be the weakness, or this could affect your head pain, etc. In this case, we can measure 14 seconds and we have that measurement. And many times we have these values and we know that can represent risk factors. For example, if it is 30 seconds, it is something that can be improved. If there is no 30 heel elevations, then we need to improve this. So, well, these values can be useful and we can make a comparison between the different parts of the body. And we also have some objects at home, and if the patient has more strength, of course, with the limb, it will be difficult to get to that failure, but we also have some objects at home that have its weight, and we can use them to get to that failure or until the moment the pain comes up. What's the moment that you are experiencing pain? Well, that appears as of the fifth repetition, and that could have this improvement for the future. We are not measuring, of course, the maximum strength, but this is something very useful to have a system and to have these measurements. Yes, and sometimes the easier tests are the ones that are more reliable. If we talk about rhinopathy, if we choose some some coins with the cold and the heat. This is something very easy, and this could easily be extrapolated to a digital environment, for example, with the heat and the cold, whether they will perceive the temperature in the same way. Well, this is a very simple thing to do. I don't think this has been object to research, but I think the values could be very similar. Yes, I don't think this has been researched up until now, but maybe the barrier of this would be that the patient is with the eyes wide open, but yes, the patient will perceive this. Or, for example, with a stick, if we want to place something between the middle finger and the skin to see if there is allodynia or if there is lack of sensitivity or conduction, well, I think this could be useful. I didn't indicate them here, but yes, those are part of the exercises I also prescribe. Yes, and these can confirm whether there is a neuropathy. The worst thing for an online examination is the reflex. For the rest, of course, we can do this. It will be difficult to test the reflex at home, and we know this, yes, and sometimes it is even difficult for professionals. Yes, for some specific reflex, it can get really hard. Okay, I will now stop sharing my screen and we can go over to the Q&A session. So Maite is asking about the public versus private system. She says, sometimes they could tell you that the professional is going to invest the same time in an on-site consultation compared to a digital consultation. How would you, Raquel, justify the saving in times in order to see more patients and therefore decrease the waiting lists? Did you understand this question? Yes. Well, the digital consultation can last the same time as an on-site consultation. I think we are saving time for the patient. And if we're going to carry out one-on-one consultations, then there won't be a time difference on most of the cases. We can save some time in the sense that with digital consultation, it will be more minimalist and the session will be shorter. But if you are already active in an on-site consultation and you want to do this on a one-by-one basis, we won't be reducing the times. The idea is to reduce the transport for the patient and to use the asynchronous tools for the patient to keep on working and not needing this one-on-one relationship. So the idea is to reduce the oversight level for the rehabilitation sessions because sometimes the patients can do this on their own. Yes, so instead of reducing the timings, we could make some management improvements so that these patients, once we have done the first analysis, if there is a good prognosis, etc., in this case, these patients won't necessarily mean an on-site consultation, and this could be saved for more complex patients. So a way to save some time would be to make this distinction, and we could work with the simple patients on a digital environment. And if we have some complex patients, we could work with them with the on-site consultations. Yes, we could make this stratification and we could set up this protocol. We could make this based on the phenotypes and see how we can work with patients, if we can have an on-site or digital consultation, and how we can do this. Okay, Maite, thank you very much for your question. Now we have a question from Sasha. He says, how a traditional session goes on. what would be the structure of a classical session, and what are the skills that you think are important in order to manage these kind of sessions. I understand she or he refers to digital sessions. Well, first of all, the professional needs to be well acquainted with the exercise prescription. The professional will need the communication tools, because some people will think that a video call is colder and more far away. So we need to maximize the communication strategies, because there are some verbal and image cues that are getting lost because you only see the face and the upper part of the body. These kind of cues are lost, and that's why we need to have communication strategies. From then on, if you have the capacity to have this active approach and work on problem resolution, approach towards a healthy lifestyle, etc., then this would be very useful to carry out this digital consultation. Of course, the more simple it is, the easier it will be for the patient, and the more successful they will be. We do not necessarily need complex tasks or any devices with lots of gadgets. No, we just need a simple tool, a very concrete one, and this will be easier both for the physiotherapist and for the patient. And when we talk about the sessions, well, first of all, the patient will contact us through different media, through the website or through the consultation. Then we set up the communication. We have to cover up all the legal part when it comes to consent and data protection, just as if we did this with an on-site consultation. And you need to be well acquainted with the situation in every country where we work. And then from then on, before having the first consultation, I try to receive the medical reports from the patient. I sent some prompts, some self-reported questionnaires to get a general idea of the situation. Then we have this session with a long interview, the selection of tests that will be done, the educational load, and the exercise load. Then on, we make a negotiation with the patient, and when we will have this next visit. It's like, okay, do you want me to see you next week or in 3 weeks? It depends. Yes, I'm from the physio perspective and this negotiation model. Of course, this is part of the system. And I think you talked about the value and the price of an online consultation compared to on-site. Should there be a difference? Well, the online sessions in my case are more expensive, I guess, because they require more resources, right? Yes. Well, first of all, my consultation is on a peripheral neighborhood, and people come to me because I am the one who is in the neighborhood, and I try to adapt to the kind of profile of people who lives in my neighborhood. And then when it comes to follow-up and the planning, I need more time for the digital consultation. If there is adherence problems, then I will use the app because I can have a registry. But if there are no adherence issues, then that's not the case. So yes, for digital consultations, there will be a higher load, and usually the patients are more complex. So for me, the price is higher when it comes to digital consultations. I also need a software, and there are some costs that come with it. Okay, we have other questions. Joseba says, thank you very much. What would be the adherence level in the elderly, because they would very much benefit from these interventions? Well, usually with the elderly, in my experience, they meet the exercise prescription better than other patients. They have more free time and they are more disciplined. Of course, I am talking about a general basis. In other cases, the children insist on this, but in other cases, they just give up because they do not like this model. And if we talk about the elderly, if they have this support from their children, from their family members, they go to the consultations and they have an excellent follow-up.
We are going to ask a couple more questions on the chat, even though it's already 8. If you could be so kind. Yes, of course. As Pau said, how do you normally organize or arrange your online consultations? I want to start doing online practice, but I don't know how to organize this and for it to be well accepted by my patients. For chronic pathologies, do you have some sort of subscription approach? Well, I actually have 3 payment schemes for online sessions. They can get one-off sessions. This is like a second opinion, criteria, an examination. But then I also have 3 and 5 session programs or packages for cases that could extend over time. For instance, like not that long ago, I had tendinopathy of the thigh and of the buttock, rather, however you may call it now. Anyway, sometimes well, they ask you because I send them a PDF with the different modalities, and they ask you, what do you think would be best for my case? Well, I think 3 sessions. We will have to increase the load progressively, but since you're performing well, and we can foresee that this injury could last like 12 weeks roughly, we can make an adjustment, and maybe you need 3 sessions. Then I have the 5-session package for more complex cases, and then I have a monthly subscription. You pay an amount a month, and I will do a call a week, and I will answer your messages every day in the morning when I open the app. If you have left a message, I will give you a 1-minute reply. And it's like a premium approach for people who really need surveillance, lots of follow-up. Okay, and Iñaki is asking us what type of musculoskeletal injuries would you say better respond to this type of intervention? Well, I've had all sorts of cases. I've had high impact complex pain cases and also some benign musculoskeletal issues like this contralateral pain of the waist or the buttock. You know what? I wouldn't dare do this with people that had erratic evolution when I had some doubts about the diagnosis. I don't know if it's a neuropathy or not, and the evolution is a bit tortuous. Well, that way I will refer them. In that case, I would refer them to face-to-face consultations, if and even more so if they're not in my geographic area. But we're talking about musculoskeletal pain here, which is the core of this webinar. But with oncological patients, we also work with them online. Okay, then. Well, at the end of the day, we're talking about musculoskeletal patients with some proprioceptive pain. Some musculoskeletal patients, they normally have additional problems, and this applies to different types of populations too. Do you have any other comments to make on slides that perhaps we haven't been able to elaborate on? Well, I did speak about it. I had a closing slide. Well, I'm going to share it because I'd like the statement, and otherwise I will just fail to quote it right. So let me skip some slides here, and I really like the fact that digital tools contribute to making a cultural change about the way in which clinicians, everyone in general, perceives pain under treatment. Sometimes we adhere to clinical guidelines, and it seems like passive treatments levels on a second level, being coadjuvants and the rest of things that everyone says they're right to do, and they can be done in this way. So it's a way of giving patients resources, of giving them tools so that they can manage their health issues, because sometimes musculoskeletal problems stand over time. And sometimes it's something chronic, but you don't need to understand it as something that you're going to be progressively worse, but rather as something that is relapsing in a way. And sometimes healthcare professionals are clear about the fact that hypertense or diabetic patients, we need to tell them how to self-manage, even if they can have some face-to-face visits when symptoms flare. But with musculoskeletal patients, perhaps the approach should be the same. We should teach them how to manage their healthcare issues, keeping our doors open. When they fail to do it, they can resort to us, of course. We do have information on self-management strategy, which is what this project very much focuses on. They can self-manage themselves, indeed. And it's not about relapsing issues. It's about patients that are going to always have these issues. Statistically true. We know that for some patients, there's a prevalence of chronic pain that cannot be modified, and sometimes, so we don't see this enough. That doesn't mean that patients will improve, of course. And even if it's not going to be chronic for someone who, for instance, exercises frequently, in a year at some point they might have a stiff neck, or your Achilles tendon aches, so you need to know whether you should stop exercising or training, whether you need rest or not. It's like a cold. It's just like a cold. Raquel, and they also sent me an additional question through a different channel. Do you use smartwatches? Do you monitor patients using wearables or some more invasive apps? I don't know if the term is right, but something that actually gathers data 24 hours, like for instance, a smartwatch monitoring sleep and other things. Well, I actually have a face-to-face patient that I see once a month because she's quite efficacious, and she also has a heart issue. She had arrhythmias too. And in her case, is very sporty, and in that case, we do use um, her smartwatch logs to see whether she can do strength exercises with serious clusters to avoid big spikes. And the number of steps is something that I frequently use if they have a watch for different kinds of patients, for cardiovascular patients, for sedentary patients. I always try and increase their walks. If I have older patients that have musculoskeletal issues, I always try and approach this every time a patient is in the field of my intervention. I don't just focus on the reason why they come to see me. I prioritize that, of course, because it's why they come to me. But I always try to improve their health in general, and I explain that to them. Sedentarism is a risk factor to have pain again, and that's something I explain to them. So I try to escalate physical activity in general always. So oftentimes I do this using the amount of steps, and measure, okay, what was the average amount of steps that you had before the intervention? They say 2,000 a day. Okay, you're going to try and attempt to get to 3,000 before next week. And I use their baseline as reference. And sometimes I also do interventions on sleep, and it really depends on the situation. But if they actually have that data, I never ask them to buy a wristband or an activity band. But if they have the metrics, I use them. Okay, Raquel, I think we need to close now because you probably have to go for dinner with family. So thank you very much for accepting to be with us. I'd like to also thank our participants, and I'm going to now show the QR code so that they can populate the satisfaction survey. Thank you very much for being with us, and no, thank you for having me and for inviting me to this webinar, and thank you for inviting me to be part of this project, a project that I really like indeed. Thank you. See you soon. Bye.